Health and Wellbeing Board meeting of the 28th of September. As you can see, I'm not Rebecca, but I'm chairing instead of in absence. Yes, decided that before I finish my 2-year term, that I at least have to chair one of these meetings for my sins. And this is atonement. I'll tell you, this is proper atonement on my part, because I'm not a very good chair. I apologize upfront for all lapses. I'm a jobbing GP, and I love to be a member of a group rather than chair any group. So having said that, Clarissa, do you have a long list of apologies today?
Rebecca, and we also have a DT, I think.
Yes,
and,
yes.
Jane, I think. I'm not sure. I haven't heard from Jane, but I think.
Thank you. There have been no new declaration of interest brought to my attention. I think there aren't any. And if there are any as we go along, we can obviously highlight it before we start discussing it. Thank you. Has anybody had a chance to go through the minutes of the previous meeting, which are in pages 1 to 4? Can I take it at page 1? You're happy with?
Yeah.
Page 2?
Yes.
Page 3 and page 4?
Yes.
Thank you very much. The next item on the agenda is item number 4, COVID-19 in Merton. There are 3 parts to it. And Dagmar, are you taking us through this, please?
Yes, I will. Thank you, Chair. Thank you, Vasa. Clarissa, if you help me with the first set of slides. So as usual, colleagues, I will give you a brief update on the epidemiology. So if you move me on. Thank you. So these are the summary figures. And the main message is that infection rates have been pretty flat, which is good news, albeit at a relatively high level. And Merton is in line with the rest of London, and London actually has been faring better than the rest of the country. I must put a little warning in, because obviously I have to prepare these data quite in advance so that you get them in your pack. And more recently, the situation has been heating up because we have increased outbreaks, particularly in schools. A number of you will be very aware, either because you have got school-aged kids or you have a job in that area. So at the moment, we are getting a bit more jittery. We've also kept a good eye on the impact on the infection, because as you can remember from my previous presentations, it is the harm from the infections that we are particularly concerned about. And so it is the impact on the NHS that we are particularly monitoring, and that has been flat. But I've spoke to one of my colleagues in St. George's yesterday, and again, they have some sense that rates might start to creep up. There's always a lag between infection rates and impact on hospitals. So all in all, I would say we're still in uncertain times. If you move us on. I won't go through all these slides. I want to leave you with you as a reference. If you move us straight on, these are the usual comparison. So these are the comparison in Southwest London. We're obviously working very closely with our neighbouring boroughs, and the latest of those, which I, as I said, didn't manage to get into your pack, shows a clear upsurge at the in the most recent days, led at the moment by Richmond, and in particular led by young people. If you move us on. This is, as I said, the impact on the NHS. You can see steady. There are still some very ill people in hospital, and we have got a big agenda item around the NHS later, so you will hear more. what is important is that the NHS is generally really busy. I think a lot of you will know that there are other infections, respiratory and otherwise, going round that are non-COVID, but making people quite ill. And obviously there's a big backlog for the NHS as well. So COVID stable, but very busy. If you move us on. These are your familiar breakdown around who is affected in Merton. We're keeping a particular eye on the East-West differential, and as you can see, it is the two lines, the blue and the red, are crossing over. And on the right-hand side, you can see the age distribution, and again, the most recent one will show you a real upsurge in the youngsters. Mainly secondary school, but also sort of going over into primary. If you move us on. This is our testing. Testing is still one of our tools. And so the message is quite important when you are out there as well, for people to do use the lateral flow tests, to access the PCR tests. So lots of availability, many collection sites, supervised testing, also all available in Merton. So there shouldn't be any issues. If people think they have any symptoms, they can get a PCR test now. And we are recommending asymptomatic testing with the lateral flow test for people that are out and about and obviously in schools. If you move us on. These were the outbreaks. You can see that schools have 5, but in fact this number has crept up, and the LCRC, our colleagues in Public Health England, are only now reporting very big outbreaks. There are thresholds in schools. There are many, many more, and they cover all schools, including our special needs schools. If you move us on. And this is your familiar map around the deaths. So luckily, death fatalities are low at the moment. You can see the 2 waves where gave a clear pattern, and luckily that has died right down. If you move us on. The other important bit, obviously, our biggest, most important tool to protect from the infection is the vaccination, and particularly in the subgroup, we've been keeping an eye on equity of vaccination, and have been working really closely with the PCNs and primary care and the NHS in vaccination. Both the comms engagement teams have done really profound work. So the pattern are that we've still got some groups with less uptake, and the pattern hasn't shifted very much. So it is still in ethnic minority groups, particularly Black groups, that we have lower uptake. And then generally the younger age groups lag behind the older age groups. If you move us on. And this again is a picture. We've also got the usual east-west divide that is driven quite a bit by the ethnic mix in the borough. You can see and will have observed, though, although the pattern hasn't changed, for us, we leave nobody behind. So every single vaccination that we manage is a winner. And so slowly but surely, after the very resource intense sprint in the summer, there's now still an offer that we call the evergreen offer. So really important to understand. There's never a closed door. So if people come round and change their minds and want the vaccine, those who haven't had it, they are more than welcome. And if they want to ask questions yet again, because they're still not quite sure, that is also fine. So really important. And then at the moment, the effort is particularly on the universal offer for the 12 to 15-year-olds. That is quite a colossal task logistically. This is going to be delivered in schools by our IMS NHS provider, and we're working with schools and parents to prepare for that. It's going to start imminently. And then there's the booster vaccination for those who already had the 2 jabs, everybody over 50, because we have learned that immunity is waning, particularly immunity to get another infection. There's good protection against serious disease, but you can still transmit. So very important, again, to promote the booster, all of you, if you've got the opportunity. Again, our PCNs, primary care groups, are leading on this. And then we have on top the flu vaccination coming. So the vaccination agenda is really ram-packed and active. If you move us on. Okay, I make a stop here. And Chair, if you allow me to see whether there are any questions around the general epidemiology and the vaccination before I then add on the subgroup recommendations. Is that okay?
Thank you, Dagmar. Yes, sure. Are there any questions for Dagmar, please? Yes.
Thank you. I'm sitting next to him, so I got to go first. This as well. Thank you so much, Dagmar. As ever, that's really useful. And you're well aware of the number of outbreaks in schools, and it's really tough for them. But what I'm still trying to get my head around is not all of those cases are of young people. Some of them are of the teachers. So is that just the teachers because they're exposed to kind of high levels of unvaccinated kids that they're getting it? And are we then seeing it being transmitted onto those children's families as well?
Yeah, so the majority of cases, positive cases in schools, are pupils. There will be the odd teacher, but by far the highest numbers are pupils, mainly secondary age. So the pattern at the moment is that we have some intrinsic school outbreaks. So there is transmission in schools, or we are assuming, looking at the pattern, that there is transmission happening in school. And indeed, there is likely to be some transmission in families with children where you have the children unvaccinated. So these are the pattern where it seems to hold more, where the parents are vaccinated. It doesn't seem to jump over. So as expected, the parents seem protected. Now we have observed, and you will have read it in the press, there's some breakthrough of the vaccinated. So some vaccinated people can get reinfected. They are often asymptomatic, but they can transmit. And the most important, therefore, for the vaccination is it prevents from serious disease more than it prevents from transmission, but it also prevents a bit from transmission. So that's this sort of upshot. What we're seeing in schools, there is some, we had a Southwest London incidence management team. We have that every 2 weeks now, where we meet up across the whole of Southwest London with our Public Health England colleagues, NHS colleagues, to look at what's happening. And it's quite interesting that Public Health England has also and is looking through survey studies at the general immunity level in different age groups. And although we have got the outbreaks in amongst the youngsters at the moment, there is some glimmer of hope, because generally the young age groups, the secondary school age group in particular, have high levels of antibodies, so up to 70% or so. So even though not all are vaccinated, they carry immunity from previous infections. And so the expectation is that hopefully the outbreaks are short-lived rather than exponentially increasing and then tipping over into community and older groups again.
Rob, you got a question?
Yeah, thanks, Chair. Thanks, Dagmar. It's actually not a COVID question, although it is in some ways. So I was just looking at that chart and around death, and just wondering how likely a sharp increase in non-COVID deaths might be this winter, and what are the key things that we as a system and within communities we can do to kind of avoid that excess.
Yeah, so I think it's a really good question, because as you have well spotted, even going back when we had the big spikes of the COVID deaths, actually we had even bigger spikes of non-COVID deaths. So the excess mortality is, to be honest, is not completely understood. There are some pattern, including late presentation to health services. But as I said, the research is ongoing to totally unpack it. And so I think, as you mentioned, mobilizing the system, saying the NHS is open, particularly for the for backlog of long-term condition care, the general preventative services, the general care for long-term conditions. These are all, in a way, our basic messages, but doubled up. And as we know, and we will touch on that in a short while in the Merton's story, because mental health is fragile, is probably a fair description. Really, the all-round support for people really, really important, loneliness, etc. And big contributors to all sorts of behaviors as well, that you then don't seek help when you actually really need it. So I think all eyes and ears out there, and that's where the voluntary sector comes in big time, because you are in touch. The message, the NHS is open, and we will hear a bit more from our NHS colleagues. Knowing or having awareness about long COVID, again, I'll give you a few numbers, and saying you don't have to suffer all in silence and loneliness. There are now referral pathways. We're all learning still, but there is help available. So I think that's the general approach.
Thank you, Dagmar. And I think, Rob, is a very important question, because we have been so COVID focused in the last 18 months that we mustn't forget there are other things which will also kill in the winter, sadly. So cold weather itself takes its own toll on people. On top of that, your normal winter viruses, even when we give the flu jab, we are only protecting 2 or 3 strains. So there's still the rest of the strains which will attack us. And because last year we didn't really mount much of a viral influenza immune responses in any one of us, our normal learned immunity would have been a bit diminished. So this time round it will be new. So we will have to face up to that, and we need to be aware of that, and we need to talk about it, because there is still in public, there is still a fear about COVID, for obvious reasons. But then every time you cough or sneeze, you mustn't think it's COVID. It could be something else. And I think that's the something else which needs a different treatment to COVID. And I think that's the awareness. We need to actually be positive and encourage people not to seek help, also stay warm. The traditional winter messages of staying warm, taking the flu jab on top of your boost. I think that's the bit that I'm looking at my own patch up there, and it says 90% have taken the COVID attack. And I'm happy that you only feature my low modern population. You don't feature my Sutton population I look after. It doesn't feature on your graph. But low modern population do me proud there with 90% up there. And I'm thinking, I don't want anyone to be complacent because they got 90% in the COVID immunization, that they don't then not turn up for the flu jab in equal proportion. That's the bit there, in equal proportion, because if one bus doesn't get you, you can't then go on to the next bus because you became complacent. So I think really none of us should become complacent in the messages about taking the flu vaccine too. Dagmar, oh, sorry, Una, I missed you. And Mark, sorry. Thanks for pointing the mark. Yeah, Una, you next, I think.
Thank you. Yeah, I mean, boosters actually is one area I think that's going to be really important. I mean, obviously making sure that we've got the first 1, 2 and all that good work, but now we obviously do need to follow up. So we're wondering what we're doing to encourage that uptake, but also with flu, because clearly that's also, as Vasa was saying, really important. And I also wondered whether we're advising, or whether the PCNs are going to be doing both together, because I know there's been talk of that, and in fact a number of research has taken place combining the two. So I just wondered where we were with that, because I think uptake would obviously be better if people were able to sort of pitch up and have both.
Yeah. Or shall I start? Maybe, and then Mark, you might want to chip in as well. So, pardon?
And Karen could do as well. Karen,
oh yeah.
Karen
Okay. I'm therefore very quick. All good points. Una links a little bit to my request that I present to you in a minute, that we want the subgroup to continue and focus on vaccination, because it has been a very helpful sort of mechanism. With regards to IMS and COVID together, yes, in principle you can give it together. There's a bit of logistics involved, because the rules generally say 6 months after your second dose you should get the booster. Now that might be a little bit too late for the flu. So where it is suitable, yes, but on the other hand, it is not a completely chained together operation either, for it to work best. But I think we've got the experts in the room, so I hand over.
Thank you.
Mark?
I was gonna defer to Karen, actually, because I think Karen's probably more of an expert than I am, and she's on the front line delivering this. So, Karen, do you want to pick up the booster, and then I would just like to go back and touch on the schools.
Yes, certainly. Yes, you're right, Dagmar. Logistically, it is quite challenging, partly because you have to ensure that people are 6 months from their second dose to have their COVID vaccine. And also the stock of the flu vaccine, where it's arrived, sits in all of the individual practices, and some practices have had a delay on the arrival of their flu stock. But certainly our plan at the moment is that for the most vulnerable, i.e. our residents in care homes and housebound, bearing in mind these were the people that were done earliest and are therefore 6 months and ready to have their COVID booster, we are planning to try and give them or offer them the opportunity to have both together. So that will be our starting point with the most vulnerable group, where we try and iron out any of the logistical issues that might present themselves. So in principle, yes, we'd be looking for efficiency. The other point to bear in mind, which is again a logistical point, is that because the booster is Pfizer, patients have to have a 15-minute observation period. So normally with a flu clinic, if you've ever been to a GP flu clinic, people come whizzing in and out. That's not possible with Pfizer. We still need to maintain social distancing. So we have to think about GP premises and being able to observe people safely and space people out. So those are some of the things we have to take into consideration. But in principle, yes, we would look to do that if we can. And we're certainly going to aim to do it for the care home residents and the housebound people.
Wonderful, thank you.
Thank you, Karen. Mark, your hand is still up. Do you have a different?
Yeah, I think that, I mean, Karen obviously proved me absolutely right. She was much more adept at that answer. I just wanted to go back to schools and just say that we, Dagmar, Jane McSherry, and my teams, we met with all the head teachers with the provider of the service, the immunisation service, to basically then offer them a kind of call so that we could do this with minimum disruption to them, but actually at their, a date that suited them, in a hall that suited them, within their premises, etc. So just to say, there is ongoing support going into the schools as well. And the community provider who does general immunisations is leading on this piece of work and is very skilled at doing it.
Thank you, Mark. Are there any questions for Dagmar? I got one for you, Dagmar. My question is about supporting teachers and school workers, because we can see a clear differential here, because some teachers are working in schools with high uptake, and some teachers or school staff are working in schools with low uptake, and therefore there's a differential. If I was one of them, I will confess to have a differential level of stress depending on which school I'm working in. So I'm just thinking about putting myself in their shoes and thinking, how will they feel about that? Because they have to work in a slightly different environment to somebody else. And how are we supporting these people then?
So good question. So it is true. The 12 to 15 universal rollout has only just started, but we have a few areas in London we can already learn from. And you're absolutely right to say there are quite big discrepancies between different schools, from lowest 10% to up to 80%. We haven't started our rollout quite yet. As Mark said, we've put a lot of effort into planning with the schools and with the parents to bring as many with us. So hopefully planning with help to improve uptake and reduce variation. But what we probably need to be, or not probably, what we are also prepared to do is that not all kids will be in school on the day of the vaccination, for one reason or another, including illness. We know quite a lot of illnesses going around. So there will be a catch-up, mop-up arrangement also. And so depending on the uptake, obviously the mop-up will be adapted. But again, I think all of us play a role. We are parents, we're friends, to try to support parents with those decisions. It is a hard ride for parents. You see, there is a lot of information out there. Teachers, parents get bombarded with all sorts of messages, some quite unpalatable, some quite aggressive, some frankly fraudulently wrong. And we have to, I think, keep calm and grounded in the evidence we have. Take all questions with honesty, and in that way try to gain the trust in order to get the uptake. But over to my colleagues, I certainly haven't got the golden recipe up my sleeve.
Thank you, Dagmar. I'm happy that we are aware of this concept of differential uptake, because some hospital workers did have some hard time in the past, where when people protested against them for giving the vaccine or talking positively about the vaccine, and what we don't want is schools to become environments of campaign and hardship for the staff going into work, because people don't walk around telling everybody else their health problems, and there are people working in this institution, be it school or in hospital, who have their own personal health problems which make them behave in a particular way. And because society doesn't really know what somebody's medical history is, then people sort of label them and say remarks, cast remarks which are actually quite hurtful, because you can't turn back and tell somebody, I got this condition, or my mom's got this condition, that's why I'm like this. So I think we just have to look out and support both our students and our staff, because we need both. So Dagmar, are you moving on to the next item, which is also?
Yes, I'm sorry for you to have to listen to me so much. So very briefly, you will have seen in your paper pack a very brief paper with the request from the Health and Wellbeing subgroup. The subgroup is recommending to the full board to extend the subgroup for another 3 meetings up till March 2022, in order to focus ongoing on vaccination equity for the reasons we've just discussed, but also focus on long COVID, or what is now called post-COVID, because we think it is a potential area for really push embedding equity right at the beginning of the development of our services. And as we've, as a board, engaged a lot with the disproportionate impact of COVID on our community, we want to make absolutely sure that those who need the services for long COVID will get access to the emerging services. So I will just ask the board therefore to recommend the continuation of the Health and Wellbeing Board subgroup for 3 more meetings.
And item number, I will now go into item number 5 on our agenda.
Great. Is that also me? Yes. You've got one more with me, and I will be speedy. Again, you have a paper in your pack which briefly reminds you that as a Health and Wellbeing Board, we have a statutory duty to produce a joint strategic needs assessment. That's quite a jargony thing, but the way we deal with that in Merton is we're producing a summary, which is called the Merton story. The process was a bit delayed and interrupted because of the pandemic. But what I suggest is, you've seen the paper that we have given you the full Merton story, which is quite a hefty document. This is for you as to use as a reference document. And what we've then done is distilled a 2-page summary with the main headlines, and I propose to go through. It's just 2 slides, and the ask for this agenda item is that you agree, because the Health and Wellbeing Board is the owner of this story, that you agree the story for this year, and then that you help to make best use. So that you help us to disseminate and share the story as a reference, hopefully useful for a wide group of people. Is that okay with everybody? Yeah, so just the 2 slides. Firstly, a reminder, as I said, Merton story is the summary of the Joint Strategic Needs Assessment, and we have a statutory duty. What's quite important to highlight is, wow, there is lots of data out there. I could give you a big tome of stuff. But the trick is to distill out in what it actually means, because neither of us has got the time to read through big documents. It is high level, it is strategic, so it cannot and is not meant to be a deep dive into particularly services. What we use it for is that if we are thinking there is an issue, then we also can prepare specific in-depth needs assessments as and when required. But the Merton story is the overall strategic view. Now, as I said, our story this year, 2021, it covers data from 2020. It has a focus on the COVID impact, and particularly the impact on inequalities. But there is quite a big but. The data availability for 2020, it was reduced. As you can imagine, everything was reduced. So data production the same. So quite a lot of the learning about the COVID impact is still emerging. So we will have to live with them in that restricted scope. What was very important for the Health and Wellbeing Board, and you have all been part of that, and so has the subgroup, is that we said data only tell you so much. What about voice? What about the qualitative aspect? What about the lived experience? So we have commissioned the different reports from our voluntary sector, from BAME Voice, for ManCap, Age UK, and our young inspectors. And although the Merton Story document doesn't cover all those, you have amongst the resources the links to all these reports. And for us, really important as a health and wellbeing board to take both sides, qualitative and quantitative, and always triangulate to really try to get the right insights. So as an overview, on the right-hand side, what has COVID done to the population? Not surprisingly, it has shrunk. Now that's quite dramatic. We're very used to populations growing, and longer term, I think there will still be growth. But during 2020, the population, to all intents and purposes, shrunk. And there were three drivers. One, obviously, the excess death. Rob, as you particularly pointed out, not just COVID deaths, excess death. Then a low birth rate. Now, some of you will remember from the previous Merton Story, we already had a decreasing birth rate, but this year was, or the COVID pandemic 2020 year was quite dramatically lower. And we were not the only one. It was a phenomenon actually globally observed. And before the pandemic, people said, well, we don't really know. It could go either way. Sometimes in lockdowns, when there's nothing else to do, you have got a baby boom. But often the anxiety and uncertainty and stress and mental and physical distress that people have been under are actually really reflected in that the births have dropped. Yeah, so it's another indicator of stress. And then finally, people have moved out. People moved out of urban areas, and because of the remote working, some have actually packed their bags for good. So that's something for us to keep an eye on, because obviously we're planning our services on predictions and projections of population counts and population proportions. So we will keep an eye. A lot of this is likely to rebalance, but it might present a more longer term pattern. On the lower bottom, just a few real highlights about the direct COVID impact. And again, the main message is not at all a surprise, but it is stark, and it is for us to act, is that existing health and social inequalities have just been deepened, sharpened, and to quite sort of distressing extent. There are some precise numbers. These are only for 2020, so you will remember I give you a death tally every time I give you a week SAR, and so this year we're over 400, and I can't remember. So it has definitely gone up. The long COVID numbers, we have better estimates now. So you already see from the time the report was put together to now, the latest figure for Merton is about 2,700. And our learning about it is, as I said, still evolving. Not all completely grim. More recent ONS studies glimmer of hope. That some of the very high estimates might not be realized, particularly among younger people and children. Okay, if you move us on. So the second of the 2 pages, we have this year structured the Merton Story along the lines of our local health and care plan and our Merton health and wellbeing strategy, just to make the read across easier. So we have start well, live well, age well in a healthy place. And again, the key message on start well, not surprisingly, is that although the kids didn't have COVID directly very badly, COVID really increased vulnerabilities for children and young people. And the particularly stark issue is the worst mental health. And it is quite easy, particularly when we were in the thick of the pandemic, to really leave the young people a bit to one side. in all hands on deck for those who are in hospitals and sick with COVID. So it's all upon us to be really aware around the situation for children and young people. And on the left-hand side, again, you see some of the social determinants, almost to domestic violence, paternal, maternal, mental health, are drivers for some of those increased vulnerabilities, child poverty. And then on the right-hand side, the mental health we've mentioned several times. For me, quite important as well. We as a Health and Wellbeing Board have had the Healthy Weight Challenge is one of our sort of focuses for a long time when we did our diabetes program. What I've learned as a public health person as well, I have to be quite careful about the framing of obesity. There has been a lot of shaming of obesity with the undermining of mental health. So the idea of talking a lot about obesity and it can actually have an inadvertent negative impact of stigmatizing. And if you think about the really complex package of that, we have indeed an increased level of childhood obesity, an increased gap between the East and the West, but we have increased food poverty at the same time, particularly in the East, and we have a real jump in eating disorders. Yeah, so when we try to just focus on obesity on its own, we're not really doing justice. So I'm glad that we've picked that up as a major theme under the Local Health and Care Plan. It was in all the discussions in the workshop that we have to be more sophisticated in our approach to achieve healthy weight. About Live Well, we knew before the pandemic that it is very tricky to live a healthy lifestyle these days, you know, particularly if you haven't got that much money. The harder your circumstances, the harder it is to live healthy. So preaching is not really cutting it. So we started with high numbers of people living unhealthy lifestyles and poor mental health, and all of this has not got better. Sometimes you see some sort of romanticized pictures of people are jogging in the lockdowns, and it's all back to you're not preparing your real food. That is really romanticized. The majority, and particularly again those who suffered more, it went all the wrong direction. And so particularly we saw the food parcels went up because we had food poverty. Not many people had opportunity to really do physical activity. It got pushed and people were crammed in. Smoking, to be honest, a lot of people tried to give up smoking. That was probably one of the determinants getting better. Mental health, we mentioned, particularly loneliness, anxiety, all there. And then alcohol use has really gone up. Around sexual health, we are looking at the moment. The figures around sexually transmitted diseases show less prevalence. There was less opportunity, so it is a sort of coherent narrative. We're looking and preparing and see whether there will be a rebound. And then finally, looking at place, I think really important. The borough has many assets. You know, we mustn't forget needs assessment tends to major on what's broken, but as an approach, we want to really work on the assets and strengths. So we have a whole list of what people are particularly fond of. What are the assets? So green spaces, for example, pretty good transport, good schools. If we think about attainment, really engaged voluntary sector. But then obviously as a place we have challenges. Affordable housing is a big one. I think we all know. the employment and the insecure employment, particularly exacerbated through COVID, and we need to see where that pans out. Air pollution, a big one. Climate change, very much in the news now. So hopefully that chimes with how you experience Merton and gives you enough to agree and approve our Merton story for 2021.
Thank you, Dagmar. Any questions for Dagmar? Una?
Thank you. And I think the report and the 2 slides from it have been well distilled. There is one bit in the report about immunizations of children, and that was another area of concern. I mean, it's not highlighted on the slide, and I sort of get that because perhaps you're focused on some other areas, but clearly it does state there that we are lagging on MMR in particular, and also the 3 diphtheria, tetanus, and so on. So I'm just obviously we don't want to not be focused on that area. It's very important. So I just wondered if you could comment on that. Thank you.
Yeah, very good point. And Una, what we've put on under the start, well, we've logged it. We've said immunizations interrupted. So it's a little bit of like a placeholder, because it is, in all honesty, we're still tidying up the data. We have got the most recent ones are looking more promising than we thought, because we were prepared for quite a drop because of the pandemic. Actually, some of the childhood immunizations are even a bit higher than the previous years, but you're right to point out we have a general challenge because we have never been particularly good. And so you will be aware that there's a reorganization in the public health system happening as we speak. 1st of October, Public Health England will be no more. And we are very much working with the new arrangements. So immunizations have been moved to the NHS. NHS England has now the full responsibility for immunizations. And already in Southwest London, there's a lot of activity, being aware that it hasn't been going too brilliantly before across the whole of London, to be honest. And so lots of effort and endeavour to say, with a new system, let's have another really good go at childhood immunizations. And locally, we are absolutely linking up. We need to be aware that our means as local authority are very limited for childhood immunizations. We are there to hold our NHS partners to account, but I haven't got any commissioning or provision of immunizations. But as the new system embeds, we will follow that up, and overview and scrutiny is normally the place where we invite our NHS England colleagues to so that we can hold them to account.
Thank you. Well, I know it is a focus, but so important,
Yes.
not to be forgotten. COVID obviously is, but measles, mumps, but I mean they're
Yes.
for childhood they're really serious as well. So anyway, thank you.
Rob, is your question part of the childhood immunization, or is it a separate question?
It's separate.
Thank you. Anybody wants to come back on childhood? Yes. Oh, no. Not fine. Okay. Thank you, Una, for pointing that out, because from a practice point of view, the very person who normally rings and chases up delayed childhood immunizations is the same person now was chasing up COVID, now chasing up flu. So you're quite right. Our bandwidth is limited, and therefore, if you don't ask us these questions, childhood immunization might suffer. So it's very important that Dagmar, you ask the question and Dagmar keeps an eye, so that we realize that we have to still chase the missed smears and the missed childhood immunizations, which we always did, but now we have redeployed our staff to chase something else, and we got to learn to do multiple chasing. I'm afraid that buck stops with us at practice level. We are the people who know the phone numbers, we know the mothers, so really we got to make that call ourselves. But continue to keep an eye on this. Rob?
Yeah, thanks, Chair. Just a comment, really. Great report, Dagmar. Thank you. I think the distillation of the 2 slides is really strong and does tell a little bit of a stark picture, doesn't it? And the thing that I kind of took from it is this overriding issue around poverty, cutting across probably all of the age groups, actually, but probably more particularly felt in sort of children and families. And I think we can probably prepare ourselves for a difficult winter before it gets better around that, with fuel prices increasing and food poverty being so prevalent. So I guess it's a call to action for us as a system to try and kind of look at that and resolve some of those things and be there for those families that need our support this winter in particular and coming out. But I think, yeah, it's stark, and I just wanted to thank you for putting it together.
Okay, thank you.
There we go. Actually, Rob made the point far better than I could. I think that time moves on very quickly, and it's just in the recent weeks that we've seen the potential impact of the fuel price rises, and it's one that we'll want to keep an eye on because of the way that will inevitably play into the dimension of impact on health. But I think it's an excellent report. We took it at corporate management team, and thanks Dagmar for all the hard work on it.
Thank you. And again, I think that summary, particularly the summary on the Start Well bit, really echoes the things that I'm worrying about at strategic level, including immunizations, mental health, and that attainment gap. So I think that's brilliant. But there's just one other point on children that comes through in the report a couple of times that I just wanted to flag here as something that I do want to do more work on, and that's about the hospital admission rates for very young children. So that's on page 53 and another page. And I've asked about this before because it doesn't seem to feed through to our safeguarding as a child protection team. So I'm just a bit confused about whether I should be more worried about very young babies and young children going to hospital. And one of the suggestions is that we might see more further investigation. So I think I'm saying, please, can we?
Great. So I think thanks for spotting it, and in a way, absolutely. As I had only 2 pages, there was a limit of what I could lift out and lift in. So it's always good to be challenged, and not everything that isn't on the 2 pages isn't important. And there's lots of things that aren't even in the report that is also important. It's a snapshot in time, and anything else, it's an ongoing process for me. There needs assessment rather than just the document. So I think the admission rates in the very young is a really important challenge. I think the NHS is very interested in this as well. So some joint work on understanding, including which of those have safeguarding issues, and those who are in other illnesses in young children, anxiety of parents with young children showing symptoms. Do my NHS colleagues want to chip in, or Jane?
I mean, shall I? I can jump in a little bit there. So I think you're absolutely right. First of all, Dagmar, thank you very much. It's really, really great. And when I talk about our local health and care plan review, we must always keep the JSNA and the Merton story in mind, because what we want to be doing is prioritising together. I think going back to children in acute, our acute colleagues have identified exactly that, and actually that we do need to do a piece of work to really understand what those presentations are about. Some are about respiratory illness, some are about anxiety in new parents, particularly in a COVID environment when they couldn't get access to, their normal primary care, and your firstborn, you worry more about your firstborn, etc. But that's anecdotal, and what we need to do is actually get under the anecdotal and really look at what we can do, and whether that has an impact on the services we deliver, and also the safeguarding issues. So it is a piece of work that I think we're about to kind of kick off with our acute colleagues.
Thank you, Mark. I can't see any other hands up. Nobody. Perfect. Thank you, Dagmar. You have no further questions.
Sorry, Chair, I'd just like to reassure, given that we're talking about nearly 2,000 children under the age of 1 here, that that is not a safeguarding, that is not a safeguarding issue. There are a very small number of children for whom there may be a safeguarding issue, but there'll be other reasons for that number of children.
Thank you. The next item is health and social care update.
And I think that's over to me, Vasa, thank you. And I apologize in advance. I think you're going to be very tired of me by presentation number 4. So I will try to be fleet of foot. And the first presentation is around the ICS update, the Integrated Care System update. Now, the integrated care system, you'll remember back at Christmas, there was an engagement paper which basically said CCGs will cease to exist on the 31st of March 2022, and integrated care systems will emerge as of the 1st of April, and that they will take on quite a lot of the statutory functions of a CCG, but go beyond that and really look at partnership and system approaches to health, social care and beyond. So the key elements of the programme, I won't go into detail here, but in the slide deck, development of place, really important. Merton as a place, and back on the back of Dagmar's presentation as well. Really important that we are able to focus on the local needs and prioritize the local needs of people. But we will do that in a framework where actually it's about providers coming together to develop and deliver services rather than the kind of traditional commissioning that we've been used to for the last 10 years. It very much puts people at the center, and we need to make sure that we are developing engagement and being really listening to the communities that we serve, and also that we've got a framework of clinical leadership. Next slide, please. Principles of transition. Why are we doing this? Well, it's to improve health and well-being for everyone that we serve, better quality of health and social care services across the board, and also to make sure that our limited resources are sustainable and that we are, basically using our resources appropriately and gaining value for money for the investment that we put there. I think there's also a recognition that actually we're moving away from kind of traditional health services, and the voluntary sector play a really key role in providing services to our communities, and also quite a lot of that preventative and preventing people coming into kind of traditional health services. Next slide, please, Clarissa. So far in our September ICS update, we have now got national guidance, particularly around how the integrated care system should be designed and what it should look like. But we are expecting further guidance as we go through. We are doing a listening event, or 3 listening events, with our health and wellbeing colleagues, with councillors, with local authorities, with voluntary sector, with Health Watch, listening to what actually they think the governance of this should look like going forward. And we've been doing those events. I think one's already happened and there's 2 more to do. And Sarah Blow and Ian Thomas are leading them for the system. Our local transition teams have come together, and in Merton, we are now, I think, probably on our 10th meeting. And that really is about bringing all partners around the table and looking at the review of the health and care plan, but also how are we going to govern ourselves going forward. Provider collaboratives, acute and mental health collaboratives are already established, and they're pulling together draft plans, and we're looking at all the functions of the CCG and where they might sit in the future, given that the CCG won't exist. I'll come to that in a little on the next slide. We also need to make sure that the system has oversight and is assured, and that we are holding ourselves to account and providers are holding each other to account on the delivery of services. So when we come to the structure, you'll have seen this, hopefully, this pie before. The integrated care system works on 3 different levels. The South West London level, the place level, and that for us is Merton, and also then with the provider collaboratives around acute and mental health. Place is really about supporting primary care networks and the delivery of joined up services at a real community level rather than kind of at a high level, and also basically to understand and identify, again referring to Dagmar's Merton's story, is really using data and population health management techniques to be able to build services that meet the needs of our most vulnerable people. It's also beyond health. It's how do we start to contribute more to health, social and economic development, and some of that food poverty conversation that we had before. Actually, what we can we collectively do to that, rather than it just be a kind of traditional health service at the end of that continuum. Next slide, please. There's been some guidance around thriving places. I'm not going to go into this in detail, but it's just to say that, you know, a thriving Merton will have a shared purpose. We'll agree that what our priorities are. We will do things rather than just talk about things. And I know that Dagmar is very keen that actually we are action orientated rather than just building a strategy and putting it on a shelf. There's no point in doing that. That we need to develop over time. The 1st of April is the start of a journey rather than the end of a journey. And so our partnerships need to deliver that. But partnership behaviours and culture are very much at the centre of the integrated care. And it is about integrated care. Next slide, please. Place will focus on all things that are out of hospital in terms of being able to govern the money and spend the money and control the budgets, and that will include community health services, some primary care provision, front door acute services, social care providers, everything that kind of goes up to the front door of a hospital. Next slide, please. And basically, again, the key points about place is working together, an approach that basically looks to improve the health of all our communities, but those that are most vulnerable, actually, what are we doing to address inequalities? Next slide, please. We should be planning at place. We should be service planning. We should be delivering services at a community level. Next slide, please, Clarissa. Using population health management and then promoting health and well-being and making sure that we're resourcing this correctly. And that resource is not just about finances, it's also about management time and management resource as well. Next slide, please. So place-based partnerships. There was 5 options in the white paper, and option 1 and option 2 felt like a step back for South West London. So actually just giving a consultative forum or an individual executive the delegated authority felt like a step back. A joint committee where everyone throws their resources into the pot and we spend accordingly felt maybe perhaps a step too far by April the 1st. And a lead provider, I think we've got work to do in terms of trust and working within our systems to make sure that everyone is clear about what lead provider arrangements mean. So the recommended option is option 3, and that's the committee of the ICB. Now the ICB, the integrated care system will have 2 boards, an integrated care partnership and an integrated care board. The partnership is where all partnership conversations, health and wellbeing board conversations will happen. And the ICB board is an NHS body. That's the NHS body that replaces the CCG. Why are we recommending that? Well, we're recommending that because it will give us local autonomy, but at the same time provide us with a smooth transition to the new world rather than a big bang approach. And actually it will give us some consistency across South West London. Next slide, please. Those committees will be chaired, and those chairs will be decided by the members of the committees. It will also have an executive lead that leads into the ICS, but actually serves the partnership. And it should include people who care and support services, their representatives, including Health Watch, but not only Health Watch. We need to have that conversation. Local authorities, social care providers, voluntary sector, the ICB, so actually someone from the Integrated Care Board needs to also be part of the partnership, and then primary care provider leadership, not commissioners, but providers, represented by kind of PCNs that are shaping services at a local level. We'll also ask acute community and mental health services to have a seat around that table, and that interface between local place and acute services is going to be really key as we want to move resources around the system. I promise I'll stop in a minute. Next slide, please. I'm not going to do that. That's basically the thriving community, and it endorses actually, but we really do need to listen to our communities and work with our people rather than do with. And last slide, please. So what have we done in Merton? So we've agreed that the committee would be the recommended option for Merton. And that will allow the smooth transition. We've started to populate some of those membership roles, which were very clear. But what we do need to do is make sure that the voluntary sector are fully involved in who their representatives are. We make sure that primary care are fully endorsing the primary care representatives. So we need to do some work and engagement just to make sure that we've got the right people and the right mandate from some of the member organisations. The health and care plan I'll touch upon in my next presentation. And then we've brought a kind of update here today, and we've already taken it to the Merton OSC. Just to be really clear that this does not replace Merton Health and Care Together Board. That is the vehicle of partnership, and it will remain the vehicle of partnership. This will be a committee that takes delegated authority for NHS budgets at the moment and has the authority to spend those budgets. There's a plan for the Merton Health and Care Together to do some organisational development, really work on us as a partnership. And we have recruited a programme director, Jen Goddard, who is driving this work forward until April. We've started engaging, as you can see, and there is a communication plan afoot. And we've also carried out 3 primary care network development sessions. We're doing this in a principle of co-production and co-design. We want to talk to people and make sure that we're doing it. And then the processes for the chair and the executive roles that I touched upon, well, they will need to be recruited to, and we'll need to agree the processes for that going forward. I'm going to take a really deep breath and stop there and take any questions.
Thank you, Mark. I don't think there are any questions for you, Mark.
No?
No.
Have I numbed you into submission? Okay, I'm more than happy to go to the next presentation.
Thank you.
Thanks, Clarissa, by the way. So, as we mentioned, Dagmar mentioned in the Merton story so far, and I mentioned in my previous, one of the first tasks of the transition team at Merton Place was to look at the local health and care plan. And we're calling it a refresh because a lot of work had already been done. And what we didn't want to do is throw any of that out, because actually we'd have done an awful lot of engagement already. So just go to the next slide. That's just giving us basically the outline of how the local health plan came together. It described the vision, the 8 key priorities, and the actions that we're going to meet the health and care needs of local people. What we're doing now is looking with a COVID lens, but also with the inequalities that really have kind of been brought even further, as Dagmar said. We need to make sure that the health and care plan is still completely up to date and we are still focused in the right areas. So we basically set up a number of workshops across the Start Well, Live Well and Age Well domains. And these have been facilitated by different people within the transition team. Some of them are here today, like John and Jane, and actually take some of the learning from the joint strategic needs assessment and the population health management work that's been going on, and basically merge those 2 things together. Have we got the right priorities in our plan? We've already looked at some of the progress that we've made in the priorities already. And we continue to engage throughout October, because although we've done workshops, what we are looking at is the attendees of the workshops, and have we missed anyone? Should there be anyone else that we're taking this out to? And we have also designed a survey that can go out to membership organisations or indeed individuals. The Merton Health and Care Together Board will oversee this process and has been receiving monthly updates and will continue to do so. Next slide, please. So we will bring back the refreshed local health and care plan in November to the Health and Wellbeing Board. As I said, Merton Health and Care Together will track it. The transition team leads will continue to facilitate workshops, but we are using other intelligence and engagement tactics as well. Next slide, please. A high-level overview of the workshops. I'm going to be really quick here. We wanted to remind people what the plan was about, review in light of COVID, and then refresh it. We've been really trying to encourage feedback and reflections on the previous plan, but also getting some of that expertise of people living with conditions in Merton, but also living with within communities to help shape the priorities. We tried to be open and accessible, tried to maximize attendance, and also done a survey which is prompted at the end of each workshop. Final slide, please. So we've had over 100 people attending the workshop so far, which is great, and that was done over the summer period. We are planning to, when we get the refresh plan, make that available on the website where people can continue to comment on it as we go through the next few months. We've had very positive feedback and had really good representation across each sector. One of the constructive feedbacks is that actually, where is the patient voice? Where is the service user voice? Can we strengthen that in the local health and care plan? And that's something that we want to continue to do throughout October. It broadly, the feedback so far is that the priorities remain relatively the same based on some of the JSNA areas that Dagmar raised, that we need to reduce inequalities further by really listening to our communities and understanding their needs, and that particularly in areas like mental health, that the pandemic has really had a negative impact across the board, whether it be young people, adults, or indeed older people. The workshop intelligence will be collated over the next month, and as I said, we'll be back in November to update you on the refreshed plan. Again, I'll take a breath and happy to take any questions. Many people around this table have been involved in it, involved in the workshop, so someone might want to comment on them.
Yeah, very happy to comment on the workshops. Thank you very much, Mark. Yeah, the one I attended, I thought was really well run. Like I say, very well attended. People were very engaged, and I was really surprised at how much kind of agreement there was. This is the Start Well workshop. You'll be unsurprised to know that I was at. How much agreement there was from across the sectors and what the priorities will be. So, I mean, the challenge will be working out how to address those priorities and how to deal with them. But no, they were really well run. Thank you.
Great. That's really good to hear, because it's really important that people are getting something out of the workshops as well as inputting into them. So that was, thank you for that. I think Rob's got his hand up.
Yeah, I'm good with my hand. Just to echo Ellie's point, really, I was also at the Age Well one, which is not a surprise that I would have been at that one. And again, the consensus among all the different partners about what the challenges were, but starting to think about how we could work together as a partnership and try to kind of work collaboratively was also really pleasing to be part of too, across healthcare and the voluntary sector. So yeah, I just think that it's been a good exercise, and I think coming out of it we're going to have a lot more clarity as to kind of how we move forwards, because I think the majority of the priorities are actually the same. They've just been intensified by the last 18 months.
Yeah, and I think it's that word intensified, isn't it? It really has kind of that. I think that describes it really well. And I think this is also just this is about a continued dialogue. It's not, we don't want to just do this as a one-off. We want to continue the dialogue so that things change and emerge, and we're kind of fluid in our ability to kind of react to things. So yes, thank you for that, Rob.
No further questions, Mark, so carry on, please.
Okay, so bear with me, everyone, because you're halfway there. I've got 2 more to do. Thank you. So we did circulate the Merton Borough's estate strategy, which is quite a big document, and it will be on the CCG website. But we just wanted to update you, particularly about the East Merton hub. So next slide, please, Clarissa. So in 2019, just taking people back, we identified that estates is really a key enabler to doing things well, and basically in being able to provide joined up services in places that are accessible to our communities. So over the last 18 months, the Borough Estates Group, the Merton Borough Estates Group, has basically produced its estate strategy, which was signed off last April. The abridged version, which I mentioned previously, will be on the website shortly, but we just wanted to bring a part of it here today to update you. As part of that strategy, we have now gone back and looked at it and looked at the objectives of our partners, as well as the impact of COVID again. And we will continuously review the estates strategy for Merton. We want to thank everyone that's been part of the process, because we do know that estates that span many years when it feels that perhaps lots of things aren't being done. But next slide, please, Clarissa. So in July, we took a paper to the Merton Health and Care Board, Together Board, asking for a mandate to proceed with the Mitcham Health and Wellbeing Hub. Now we're calling it that because actually many people call it the Wilson redevelopment, etc. But we are now in part of a process, and we felt that Mitcham Health and Wellbeing Hub described what that described the locality rather than the building. So, however, we wanted to ensure that proposed services continue to meet the needs, and particularly in those areas of high deprivation and high need. So we were pleased that actually we got the mandate to proceed, and a programme board's been established, and it meets for the first time on this Thursday. And that will basically set about the subgroups that need to drive the work forward, to then really putting together a health and wellbeing hub in Mitcham. Now, I have to say this, and I have to express this, the preferred site is the Wilson, okay? But when you, as part of the process, and I know this is very bureaucratic, as part of the process, you do have to, when you're starting to write an outline business case, you have to revisit options. So when people are saying, oh, you're re-looking at the options, that is part of the process. And I really want to make it really clear. The NHS preferred site is the Wilson. And as we go through the process, I think that will become even clearer. The first objective of the programme board, which meets this week, is to make sure that we scope out those options, and we have to have that completed by November. And I think now we will start to see some real progress being made. And I know that it's been very frustrating for everyone involved in it, that it kind of has been not dormant, but we've been working with property services to try and get the right resources in the right place. We think that that has now happened, so we can proceed to actually getting that business case done. We want to regularly come back and just update you on the progress, but we just wanted to come today to say, the first programme board is actually this Thursday. And I'll stop there.
No hands up, Mark. So, oh, sorry, John.
Mark, it might be useful if you give an update on the timeline for the Wellbeing Hub. I mean, when would the go live date be, do you think?
Okay, so I think we're working to a time frame, and I can see people guess is probably around 2025. So it's really important that we don't then think that the Mitcham Health and Wellbeing Hub is the answer to all our questions and all our answers now. And it does go back to conversations I've had with both John and Dagmar, is that it's really important that we are doing things now. And we are building for the future, but actually it is really important that this is not seen as we've ticked that box for East Merton. We've got a lot to do in Mitcham and East Merton, and we need to do some of that now and not wait for a building. Thanks for that, John.
Thank you. Back to you again, I think.
Lord. Okay, okay, so final presentation. And this is about community diagnostics hubs and the plans across Southwest London. So it says Dr. John Clark and myself are going to present this, but unfortunately John couldn't be with us because of other commitments tonight. I will be relatively quick here. So next slide, please. We'll give an overview of what the hubs are about and just the plans for engagement going forward, and try to answer any questions. Oh, I think John might be with us now. John, are you with us?
Yep, I'm here.
Ah, okay. Well, shall I do the opening and then perhaps you take it from there?
Yeah, please do.
Yeah, so just to say that the NHS nationally is providing funding for community diagnostics hubs, and that's really to help manage the backlog created by the pandemic. But we do also think it will improve care, reduce waiting times, and address the demand that has been kind of generated by population growth and some shortages of skills. So we have bid to create 3 new community diagnostic hubs in Southwest London. These will create faster access. We'll envisage that people are able to have multiple tests on the same day and be seen more quickly. And they'll offer a range of tests and scans, including X-rays, cardiology tests, pathology, phlebotomy, endoscopy. Next slide, please, Clarissa. And John, do tell me to stand aside if you want to jump in. The 3 hubs that we're planning are the Queen Mary's Hospital site, St Helier Hospital, and a further location to be identified in Croydon. Those locations have been selected because they are felt to really be able to help address health inequalities and meet the local needs of people. And we are looking continuously at the diagnostic services that will be provided at those hubs, but there will be satellite sites that support the hubs and are around the hubs as well. We're engaging local people, staff and key stakeholders, asking their views going forward. But we've already been awarded 12.4 million to increase the capacity and the diagnostic site at Queen Mary's Hospital. Next slide, please. Really important that these address health inequalities. And this slide just depicts which sites we think will be using which diagnostic site. And for Merton, that would be primarily St Helier, but also some links into the Croydon site as well. We think that the best way of addressing inequalities is to locate these large hubs where we know that there are deprived communities of need. And so actually by putting them there, it addresses some of the access issues that have been reported back to us. We also do think there will be satellite sites to expand into the community to make sure these are really community services. For Merton, the satellite sites would be the Nelson, the Wilson and Rains Parks. So that's indicative at the moment. Next slide, please. The timelines. So we're already in the kind of looking at the modelling, working with our finance leads, looking at a workforce plan, an engagement plan as part of the reason myself and John are here today, and then also moving to, in December, to kind of have our plans socialised and agreed, and then drafted and moving to the kind of implementation stage of the development. Next slide, please. John, do you want to say something and rather than me doing all the talk?
Yeah, I'll give you a chance to take a breather.
Take my breath. People are sick of my voice.
So my name's John Clark. I'm a consultant microbiologist that works at FEPS and St Heliers. And for my sins, I'm the clinical senior responsible officer for diagnostics in South West London. And this whole project has kind of arisen out of work that was done about a year ago now, and is really, as Mark was saying, looking to address several needs around increasing the diagnostic capacity, because we know there's not enough diagnostics to help support all the patient pathways, but also taking some opportunities to learn from the COVID. And historically, what you do with diagnostics with your X-ray departments and your endoscopy departments is you put them in your hospitals where all your doctors and nurses are. And one of the things that doesn't go very well is when you have a respiratory virus that is highly contagious and forces you to shut things down, it really affects diagnostics. And so this is an opportunity to actually put some of the diagnostics out with the acute hospital setting into more community-facing sites. And then really what we're looking at is how do you then take advantage of having lots of these diagnostic modalities in the same place for patients who are going through their kind of pathways. And this is why we're kind of, what I've been looking at in terms of the clinical service models with some of the clinical leads across South West London is how can we look at our existing referral pathways? So if you have a patient with breathlessness that sees their GP, they may go have an X-ray, come back to the GP, get that review. So we need to refer you on to the cardiologist. You see the cardiologist, then they say, well, we need to get an echo of your heart, a scan of your heart. So you go off, have that, come back. Well, that didn't show anything. We need to do a treadmill test. And so you go backwards and forwards. And so your pathway is many weeks to months long. And so can we actually look at doing things differently by saying, well, would a patient be happy to say, well, come along to this place, spend the day here, and what we'll do is, you have breathlessness, so GP refer you to then have the X-ray, someone look at it there and then to say, right, well, we need to go the next step, and then use the results to guide the next step, so that by towards the end of the day, or however long it is, you have almost got a diagnosis. You get then referred either to the specialist who's happy to be cited there or not. And so it just kind of condenses and makes things better. And what we want to do is overlay the kind of areas that are flagging up as problematic and traditionally very difficult, such as cardiology, respiratory, some of the breathlessness, some of the kind of gynecology and ophthalmology, some of the eye things, with where are the areas within South West London where there is greatest clinical need. And so a lot of work that's been done as kind of foundation work is looking at all this population health analytics to see, well, can we see where the longest waits are, where the highest rates of patients not attending or requiring further investigations. And when you map that alongside deprivation, alongside population density, alongside those various clinical pathways, you start to build up this map, which showed us very clearly that across South West London, there's three real standout areas of need where the health inequalities are not, or are the most wide. One of those kind of Roehampton and Queenstown up in the northern parts. You then have East Merton and Carshalton kind of in the middle bit, and then over into kind of the east side you have Croydon. And that kind of works very nicely with where we're looking to try to use existing NHS estate, but also looking at transportation links, time taken for patients to get there. And that's why we're kind of starting to settle now on Roehampton, which was a fortuitous site that was being renovated anyway. And we managed the opportunity to bid for some money for the kind of the year one. And then for the kind of next 5-year plan for this is to utilise the St Helier site as part of the rebuild on the Epsom St Helier estate to convert some of the buildings there into the diagnostic centre, and then somewhere in Croydon that we haven't quite landed where it's going to be. But as I was saying, between the hubs and the spokes, we're hoping to basically cover the whole of South West London with more diagnostics that are patient facing. So the next slide, please. And so what have we done so far in terms of staff, patient and public engagement? So at South West London level, there's been work done alongside work done in London, which has been led by the Imperial units. And whilst there's been small numbers from South West London for that, we've actually been doing our own South West London People's Panel. And so we've been getting people's feedback. And I'll come on to that in the next couple of slides, but the plan is to kind of use that feedback to come up with the initial plans, of which this is the first step, to then go into more engagement work, which will be again barrow-based engagement. So the next slide, please. And so what's the kind of feedback from the South West London survey? So we've actually got 720 people to come back. And as you can see, they're kind of scattered across South West London. And what is very clear is that people have a lot of interaction with diagnostics, be that phlebotomy, blood tests, or imaging, and a lot around the existing hospital sites, because that's that's where a lot of these diagnostics are based. Whilst we had responses from all ethnic backgrounds, the predominant background was white. Next slide, please. And what was important to them? Well, they were feeding back primarily on the friendliness, the attitudes, behaviour of the staff, the kind of how they were managed and looked after when they were having their diagnostics investigations done, the quality of the treatment. But there are things that they say, well, actually, that we could do better. You know, having some kind of joined up, particularly around the kind of GP hospital interface, waiting times. You know, how long it would be to get a scan. And if you go to the next slide, what people were saying really actually mattered. So it was getting a scan quickly as opposed to where it was, which was quite surprising because we were worried that distance would be a real thing. Parking was a concern, but actually not a massive concern as long as there was good transport links. The accessibility to be able to book and have the opportunity to say, well, you can go and have a CT scan tomorrow on the Kingston site or that hub over there, or you can wait and have a local scan done X. And so people wanted that opportunity. And in order to enable that, we do need to make sure that everything is integrated together so that wherever you have your investigations, it all feeds in. They wanted the staff to be trained and communicative and being able to kind of reassure and tell people what the results were. And as I said, the things that people really wanted was a kind of quick, responsive service, so short waiting times to aid getting the diagnosis quickly and being able to book appointments that revolves around their lifestyles. Actually, what was less important was where it was, when, and actually parking, but there we go. Next slide, please. Some kind of general comments that were fed back to us from the kind of engagement work done to date is that, it's very important that we don't lose track of making sure that these large hubs don't turn into these impersonal buildings, and that there's dementia friendly, that there's child friendly, autism friendly, and that staff, whilst it may be a busy unit, they take time to actually explain what is going on in the results. And again, as I was kind of alluding to earlier, one of the other things is having this joined up process so that if you go and have the diagnostics done, it feeds back into this pathway so that you're not kind of left waiting to get an appointment with a GP again. There's a natural handoff to another thing. Next slide, please. So if you just go into the appendix, just very quickly. So next slide. Ooh, I don't think. Never mind. It was just that there was a map that showed you where the kind of various places were, and there we go. That's our existing one. So if you go to the next slide, which is, so don't worry too much about the ones on the right. If you look at on the left, the map with the blue, with the red dots and the yellow dots and the green dots, what that's basically shown is the kind of average travel time. And so one of the things that we're very keen to do is to make sure that there's equity of access. And so what we want to make sure is that wherever the hubs and spokes are, they're deployed in such a way that no patient has got to travel more than about 20 to 30 minutes to get there. And it generally works apart from the little bits at the bottom, which I believe is Cheam, but actually is being captured by the Epsom site. But what we're looking at is this kind of model of the hub and spoke. And I'll probably stop there because, as I said, this is a work in progress. There are still very early stages in terms of planning for this. As I said, there is a kind of 5-year strategy that we're building up. But what we want to do is just show you where we got to now, and I'm very happy to take any questions that you may have.
Thank you for that, John. Yeah, done.
I don't know who chairs this, but I'll just look at my screen.
Thank you, John.
Dagmar's got her actual hand up, so if
Yeah.
it's not with you.
Dagmar?
So hi, thanks both Mark and John. Really helpful to get the overview, because obviously lots of work is happening. Really essential work. So the recognition that diagnostics are such an important part of healthcare, and that there is a real shortage. So all absolutely excellent news. Delighted that there is a real focus on inequality. We as a board, that's what we are very much about, so that is on the radar. I think Vasa has mentioned before, particularly around diagnostics. It can be you vote with your feet. The more vocal you are, the more you get. And if there is a much better offer, but also that there are the advocates who know that there is an offer, that will increase uptake. My question to you, in a way, as we're in the design phase, is really how we square the issue that when we talk to people, and particularly throughout the pandemic as well, they're all reporting back that they want holistic care, that they are a person belonging to a family, living in a community, and splitting the way diagnostics work in a hub is very much, that's your liver, or that's your heart, or that's your knee, or that's a bit of you. And so making that bit part of care that is holistic will be quite a challenge, because it is somehow feels quite different to what otherwise we try to create in terms of integrated offers, mental and physical health, social and in healthcare, upstream, downstream. And now we're just carving out the diagnostics. So just a little bit of reflection, how we square that and how we can help doing it.
Yeah, so you're absolutely right. And it's interesting to note that when the Mike Richards report, which is this, came out, it was just diagnostics. How do we increase diagnostics? We just want more diagnostics. And then it's morphed and evolved over the last 12 months into, well, actually, this is a perfect opportunity to actually fix some of these patient pathways and actually have a more seamless, integrated way of practicing and delivering some of these kind of patient care. And so, yes, so we're looking, and I'm working very hard with kind of some of the clinical leads across the South West London Platts to see how we can stitch it all together, especially around things like frailty, because obviously that's a multi-system, I say illness, but a condition where it's not just well, we need to get a CT head to see what's going on, but actually at the same time, we need a medicines review, we need a dietetics review, we need an OT and a physio review. So what we're trying to do is work out what we can deliver, because obviously I don't know what the budget will be for these things in X many years' time, or what the floor plans will be, but what we're trying to do at this moment is scope out what the need and demand is. So absolutely, yes, I'm very keen that we do bring all this and knit it together.
Thank you, John.
John, I would probably just jump in there to say that we have the Merton Health and Care Together board, which is the place to knit it together. Yeah, so that just we have a forum where we can, picking up on Dagmar's thing, where we can put that conversation and that kind of try to integrate things more through that forum.
Brilliant.
Thank you, Mark. Simon, I think you are next.
Thank you. Oh, sorry, I'm very dark, but I was just picking up, both respecting Dagmar's point, but picking up, John, on another sort of initiative that I think, takes things forward in terms of how health is delivered in the borough, which is great. And I know you've obviously done a lot of research already. Just pick up on a couple of things about, pressures we got at the moment around appointments, which you touched on, but then the sort of having a day sounds like a really good way of cutting down, 6 or 7 appointments and maybe putting them into one day. The point I really wanted to make, you touched on that that you were planning that there wasn't more than 20-30 minutes of getting there to a centre and things like parking. But one of the issues that has rumbled along in the pandemic has been about transport and access for particularly maybe some of the more frail members of the community. And as you touched on frailty, I wonder if what we also need to think about, again, respecting Dagmar's point, is can we look at the pathway from the person's home back to the home, and then how, if it is a day of activity, how that's well supported other than just with the medical interventions. And I sort of think of that from a volunteering point of view, because there are very developed schemes where residents take other residents to appointments, but I'm also thinking of at the sites whether there's maybe not just volunteers but people who provide that extra sort of getting them from one bit to the next, etc. Because I think one of the things we've had is a huge success with volunteers supporting vaccination centres, and I think we should remember how much that affected the people who then went for the vaccination, particularly if they were hesitant or nervous. So I just wonder if we ought to, as we sort of progress further, look at sort of door to door rather than just, I know you're not, but just the service that they receive when they get there.
No, very good point. And
thank you.
As you say, the patient journey. At the end of the day, the patient is the point of this. So, yeah, I mean, I'll make sure that we feed that in, because, as you say, the kind of home to hub to home bit, we just need to get right, because, as I say, this is an opportunity, and it is early days, to actually do something pretty seismic in terms of how we manage some of these. It won't be everything, but some of these conditions and how we manage some of these patients. So, yeah, I'll make sure that that gets factored into our assessments and how we work through some of the accessibility bits for it.
Thank you, John. Karen?
Thank you. If I could be cheeky and just comment on 2 things, if that's okay. Partly picking up on Dagmar's point first. Obviously, I would support streamlining of people's experience and investigations, but I'd be concerned that we don't, the way you sort of described it earlier, end up with people actually being over investigated. So that's the first thing to say. And also, I think the holistic thing is really important, because when you potentially go down symptomatic pathways like breathlessness, we don't want people to be put in at one end and come out at the other end, their chest x-ray's okay, their heart's okay, but they're still actually breathless. So their problems haven't actually been resolved. So I think we do need to think holistically about people when they're going down those sorts of pathways. So that was the first point. The second point, as a GP who's worked in East Merton for very many years, I won't say how many because then you'll guess how old I am, I know that actually a lot of patients in East Merton are quite reluctant to travel to St Helier because it's not actually that straightforward a journey. When I've driven from East Merton in my car to St Helier, and I'm often pushed to do it in 20 minutes, depending on the traffic. And there certainly isn't a direct bus link that I'm aware of that would get you there in 20 minutes. So I'm not quite sure how your transport and travelling times were calculated. I also think on the feedback survey, you had 75% people who are white giving their views, but that certainly doesn't match the ethnic mix in East Merton. So I'm wondering whether you might need to do a bit more sort of detailed work actually in East Merton to get a clearer view from all of the different communities there. So really what I'm saying is I think if it is St Helier, from an East Merton perspective, then you'd need to make sure that there's a really good transport offer, picking up on what Simon's just said as well. And also that your satellites, because obviously the Wilson was suggested as a satellite, that they're actually up and running at the same time as the hubs open. And also for the lower level diagnostics, think about things that can also be and are already being offered in practices. So I think you need to look across the whole piece when you're looking at your spokes that are connecting up with your hub. So thank you for listening. Those 2 points are what I wanted to say.
Yeah, so again, really holistic, I agree with you regarding the transport. So the kind of 20 minutes was transport between the hubs or the spokes. And I think what we need to say about the spokes is it's not been decided yet what needs to go where. And we need to be working with everyone to say, right, well, what do we need to say put at the Wilson? You're absolutely right. You know, these things need to come online at the same time or very close. Otherwise, you end up with this kind of discongruity where you're trying to get someone, but you don't have that thing set up yet. So we will look at it. As I said, I mean, I have to travel to St Helens every day, so I'm well aware of the fact that it's not ideal, but it is on a couple of bus routes. But as I said, you know, I will certainly look at it. And in terms of patient feedback, there is ongoing work to kind of continue to get patient feedback. So I will feed back to them that they need to get feedback specifically from East Merton, if that makes sense. But thank you for your comments.
And Karen, just to assure you, I think that's really, really helpful, because that's why we're here. We want to get comments, we want to get shaping, we want to get people to contribute to the programme. I think, as John said, it is still quite early days, isn't it? And this is the part of a longer strategy. So all these comments will be thrown into the mix, and also just to provide some assurance. So certainly the comms and engagement team, Charlotte Gone, etc., are really exercised about that 75% and how do we change that number. So just to say that has been recognised, and it is something that we really need to get to perhaps do the engagement in a slightly different way to capture some of the communities we're trying to capture.
Thank you, Mark. Are there any other hands? So John, I think we have to go back to the inverse care law, and we have known about the inverse care law for a long time, and very often whatever we do, it's not our intended consequence, but our unintended consequences that we prove the inverse care law still applies. And I think one of the ways of trying to mitigate against that is to have targeted consultations in East Merton to begin with, so that not merely asking people the feedback about this concept, but increase the awareness of this concept. Because unless you really start believing that this concept of early diagnostics, which has been our Achilles heel, our bottleneck in most of our pathways, historically, people, that's learned behavior. We in England shrug our shoulders and come to live with it and accept it. And now we are going to say, no more, we want to change it. But when we change it, unless the awareness of people in East Merton is raised, and they know to go to their doctor or go to their nurse or go to whoever they need to go to get into this pathway, we will carry on perpetuating inverse care law. So I'm really keen that the consultation is the first step of the beginning of increasing awareness in people's mind that we no longer need to suffer in silence, and we no longer need to accept diagnostic delay as part and parcel of life. That's the first point, and I think Karen said it slightly differently, but I think she meant the same. The second issue is I'm aware that you're working with the network leads. We've got 15 or 16 of them, and I know you're working with them to try and embed your care pathways into the diagnostics. So we're not actually doing standalone diagnostics, that this is part and parcel of an established care pathway across all these 15 clinical specialities, which really mean about 4 or 5 pathways in each one of them. So it's covering about 70 common and important conditions, which will no longer have the diagnostic bottleneck. But because the pathway is already established by most of these networks, people can also start the treatment, because what we don't want is to solve one bottleneck and then have another bottleneck where you know what's wrong with you, but no one can deal with it for another 6 months. So, and I think we need to sell this message to the public so that people don't sort of say, well, what's the point? You'll do this for me and then do nothing thereafter. So we need to keep the positive message of this going. And John, when we get this right, we will truly have one-stop clinics in UK, because we have been talking about one-stop clinics in this country for a long, long time, but we struggle to achieve the one-stop clinic due to diagnostics. But you're solving one problem, but we also need to have the workforce to deal with all that. And I know you're focusing on that, but to me, the public are the key here, to start believing in this new way of doing things, so that people get an equal share of the pie. Otherwise, I go back to my first point about the inverse care law, which we really can't afford to keep going on forever.
Absolutely agree. I mean, I will say that this is just the very start, and we will be back, because one of the things that, this isn't just about let's just carry on doing what we've always done, have a building with a scanner in it and everyone comes to the scanner. I'm currently working with people in the Croydon area about, well, what do we do to actually take the scanner to the people? How do we actually increase our pickup rates for things like screening and stuff? And, there's lots of already good practices out there that we do for things like breast screening. And, how can we utilize that for things like blood pressure checks and pulmonary functions? And, some of these things that are not necessarily people think, oh, I'm just a bit breathless, I'll put up with it. So you're right. I think we need to be looking at how we do things differently and get the patients on board to show them that this is a different way of doing that is for their benefit. So yes, we will no doubt be back again at some point with an update, and probably at that point asking for help and assistance. This is really just to show you this is where we've got to. This is our kind of grand thoughts at the moment, and there's a lot more to do.
Thank you, John. Any questions? Any further questions? Thanks. Mark?
I think that might be me finished.
Thank you. So I think we've come to the end of the agenda. There will be no any other business brought to my attention. But are there any from the floor? No. Thank you. So I bring this meeting to an end. I honestly don't know when we are meeting again. I should have found out before I sat in this chair, but it's too late now. November. 15th? 23rd of November. And I'm very happy that Rebecca will be back in this seat on the 23rd of November.